Hey, robotic surgery collaboration. Welcome back to Between Two Surgeons. I got Gene Dickens and myself, and sitting between us is Andrea Pakula. She's a surgeon from California, and she's going to tell us a little bit about herself, and then we'll start talking about some acute care stuff.
Yeah, thank you guys. Happy to be here. Yeah, I'm a general and trauma acute care surgeon in Southern California, and I'm the medical director for robotics at Adventist Health Simi Valley.
Nice. Sweet. Yeah, so you've sort of become a known person to talk about the robot in the acute care setting. I do some of that, not as much as I'd like, and there's a lot of resistance on many levels to using the robotic for acute care. At least there used to be. It's getting better. Can you talk about some of the resistance things that you're seeing, what other people might be encountering, and how you sort of overcame the pushback to doing that? Because that's a real common thing we read about on the robotic surgery collaboration.
Yeah, absolutely. It's something I get asked about probably on a daily basis from surgeons. I think the biggest pushback comes from a couple of different areas. One is the administrative level, right? They don't see the value in utilizing the robot at all hours. And that, I mean, the way to overcome that is us having to push it and show our data with patient outcomes to say that patients should receive the same type of care, level of care, any hour of the day, any day of the week. And then, of course, there's the other piece with respect to the staff that's trained or not trained. The robot runs from 7 to 3, and then everything shuts down. And to me, the robot is just an evolution of minimally invasive surgery. So if we're going to utilize a tool during the day for our elective patients, it doesn't make sense that we shouldn't be able to offer that to the most sick patients that we want to get out of the hospital sooner.
Yeah, I'm like the worse the gallbladder, like the more I love the robot. It's true. So there's a pushback on many levels, right? So cost is one of those things that they push back. There's a lot of cost concerns amongst administrators. So how did you overcome the cost question and drive adoption of the robot for after-hour stuff? How'd that conversation go, and how did it evolve?
Yeah, I mean, I think it comes down to there's different types of cost, right? There's the cost of the tools that we're using or the instruments, but then there's the overall cost of even patient hospitalization. And if we can get these patients out of the hospital faster, out of the OR faster, the more we do it as surgeons and the more hands-on we are, the better and more efficient we're going to be. So they ultimately, I said, compare my cases to the other operations that are being done laparoscopically or open. Look at gallbladders that are being converted, or look at injury rates. Compare that to mine or whoever's outcomes that are doing it this way. And ultimately, they saw that it was cheaper. I'm cheaper across the board with the majority of operations than some of my colleagues who are doing this laparoscopically.
Yeah. So what kind of cases would you say today are not MIS cases, not robot cases?
For who?
For you, yeah, just for you.
I'll be
Someone
honest,
with skill,
I dock the robot for pretty much everything.
Okay.
If it's an elective case and it's an abdominal wall reconstruction and that patient has a big skin graft and it doesn't make sense to do it MIS, then that's one thing. But every acute care case that comes through the ER for me, I dock the robot. Worst case, we're going to convert. And I'll have those conversations even with anesthesia. For instance, I had a feculent, peritonitis from perf diverticulitis, and the guy was hypotensive, he was tachycardic, and I said to anesthesia, look, I'm going to do this robotic. If at any time you're concerned, you let me know and we'll convert. But just that communication, and we're able to complete the procedure.
Yeah, don't you think there has to be some trust there when you're pushing the envelope, from anesthesia to trust you that you're going to be efficient, you're going to make good decisions, you're not going to be just stuck doing it this way to do it that way?
Yeah, absolutely. And when I talk to surgeons that are wanting to incorporate robotics for their acute care practice, I do caution them and I say, don't start with the most complex of case. Push it with the gallbladders, maybe the incarcerated hernias, the things that, the patient's more stable, you can get through it. And then as you become more efficient with those cases, your team becomes more comfortable, then you can push the sicker patients to be able to do those operations.
And what's your assist? You have a bedside assistant. How does that? I mean, do you feel like having competent bedside assistants makes it easier to do after hours work?
So my team is the same regardless. Everybody is trained, all nurses and all techs, and that was important to me because I'm an acute care surgeon, and I told the hospital, look, this is how we're going to do it. I'm going to potentially use the robot for every case. My OR is the anesthesiologist, myself, my tech, and a nurse.
Okay.
We don't need an assist. That's the beauty of the robot. It often eliminates the need for assist. So during the times, even with COVID, and we're doing these cases and we're so short-staffed, and I think this is a big, just as big as of an epidemic as COVID has been, is that we are short-staffed. We have travelers coming through. We don't have everyone that's necessarily trained. And that's the nice thing about not needing that many people in the OR. So it doesn't matter, one tech, one assist, and that's fine. As long as they can exchange my instruments, we're good.
So there's that administrative pushback, which you've obviously overcome, which is great. So then you get into the nitty-gritty of like the techs and the nurses and the eye rolling. They're breaking out the robot for this case. This is, the surgeons are bad-mouthing you behind your back. What are you doing that for? I can do that case in half the time for half the money. Blah blah blah. Like how did you overcome that nursing and tech mentality, right? So for me personally, they didn't want to start posting cases later, at 3 o'clock, and that was it. So then I would just sort of start adding cases on and sort of, well, you got to do it. I got the patients here, we got to do it. And so that's how I sort of forced the issue. And then eventually it just sort of rolled around and I kind of got there. But how did you overcome that sort of mentality and how was the change in the whole philosophy
And
of
the
those
culture.
people? Yeah, the culture.
Yeah, it definitely. I mean, so I've been a part of building a couple of different programs, and in the programs that already had the robot happening during day hours, and then I come in and I say, hey, I want to do these after hours and on weekends cases, absolutely got pushback. And so I went to administration and I went to the OR director and I said, let's take a couple of weekends. I will be there. I'll bring in, the rep from Intuitive. We'll have lunch and I will get hands-on. We will get hands-on with everybody so that they're trained and they're comfortable before we start pushing these cases. So in one hospital, it took a few months. I was giving talks. I was getting them excited. Just something as simple as showing them a talk with videos of ICG really gets people engaged to understand why it is that we're doing this. And then as you start to do these cases, even the recovery room nurses are like, your patients leave so much faster and without any pain medication. This is great. So it takes time to get that buy-in, but I think just educating them, taking the time yourself to show them how passionate you are about it and your belief in it, and you're willing to, I told them, I'll scrub out, I'll drive the robot in with you. Like, it's not, it's not that hard. We'll do it together. I don't mind taking the extra time to do that. And to the point where then they're like, hey, it's Saturday at 9 p.m. We're doing this on the robot, right? And it takes time and dedication from everyone. But
Yeah. So how much time did it actually take? And that.
I mean, so
Just trying to give people a feel for how long.
I think over the
this
course
is
of a
gonna
couple
take.
of months, to get your entire staff trained, it's going to take a couple of months. We do dry labs. They do the modules. We even sent some of them to a lab so that they can get hands-on training. I spent the extra time. I just came and gave little, hey, 6 o'clock, let's huddle into the OR where the robot is, and I'm just going to run through what all these, parts are. A couple of months, and then we're able to I'm going to start pushing it. Like you said, I'm going to add on that 8 o'clock gallbladder now. Hey, it's midnight. Got a perf. I'd like to do it on the robot. You will get a little resistance in the beginning, but they're going to start to see the benefits. And if you're efficient, they're going to see that we're faster. We are faster and I can be cheaper. And overall, it's about the patient. The patients are doing better.
Yeah. Okay, I have a one-off question.
Okay.
Weirdest use of a fluorescence on-call?
Weirdest?
Like the most sort of like what a time you've used it whenever you thought, I didn't think this would have been helpful, but it was helpful. Intrathoracic stomach, incarcerated stomach, proven viability.
I mean, definitely use it for viability for any incarcerated or strangulated hernia.
Perfed ulcers?
Perfed ulcers I've used it for. It's been seen, even if you don't know where the bile is, you're looking for something that's leaking, that will help you to find it.
Yeah.
I mean, I love ICG, so I
Yeah.
use it
Yeah.
as much as I can.
I put it on my cereal in the morning. I mean, that's how much I use it. I use it for everything.
You have that ICG flex-seed? They have that now, kind of
It's
combo
good. You have to crush
on
it,
Amazon.
otherwise it doesn't.
Yeah,
It doesn't get
yeah.
released. Yeah. So, I'm a huge fan of ICG too. I mean, gallbladders, all my colons, everything. How about since you brought it up, what is the weirdest acute thing you've used it for?
Man, even for like peristomals, one of my nurses, I can't remember if it was like an ileostomy or ileoconduit, something weird, and she was like, hey, why don't I was like, I can't even tell what's bowel and what's hernia sac here. She's like, can I just squirt some down the stoma? I was like,
That's great.
So, put a Foley, balloon up, and literally like real time, I'm like, oh, okay, that's the bowel. So I'm like freaking out over this hernia sac over here, and now it's like, okay, it's just a hernia sac. So perfed ulcers, I think huge. Unfortunately, perfed common duct, duodenum after ERCPs.
I had a patient that swallowed a razor blade, a full razor blade, and so did the gastrotomy. I didn't use it to identify the razor blade. I knew where it was. It was lodged in the pylorus, but just to, for fun, look at the stomach after I closed just to make sure there was no issue. So that was kind of a fun case. Yeah.
Yeah, we used to use, just contrast for G-tubes. If you do like a lab G-tube or robot G-tube, just make sure there's, no leak. And now we do it with ICG. I think it's a little more sensitive. But anyway, that was the sort of one-off asterisk question. But,
So if you had to go through, because a lot of people are struggling with this whole thing, so to look back at it, if you had to sort of put it in a stepwise order of progression, how did I get there to incorporate the acute care surgery robot? It sounds like it started with administrating and then really having your data, right?
Absolutely.
So the data is, once again, as always, the data is king. You have to have your data. And so then you showed it was cost effective and better outcomes. And then you got them on board. And then from there you went on to
Educate the staff.
And get them on board.
And like I said, I've been a part of a couple of different programs, and I have made mistakes in trying to push for the acute care. And what you don't want to do is shove it in their face and say, we're doing this, like it or not, because that does not work. So what I have found over the years is absolutely is collect my data, present to the administration, because they have to have the support. They have to share that kind of vision with you with respect to building that type of a program. Then educate the staff, educate the nurses, educate everybody so they know why you're doing this, and get them to be a part of it.
But they see your passion
Absolutely.
for it, right?
They see the passion, they see the enthusiasm, they understand, okay, this, get them excited. And I invite everybody in my hospital into my OR. I say, come look at what I'm doing. Come look at what we're doing, and, just sit at the console, and they're amazed. It's as we all were in the beginning.
Invite the administrators into the OR, let them sit on the robot, see what you're doing, and it's really eye-opening for them because they're not in the OR. That's an intimidating space for them.
Yep.
okay, my last question. So how reproducible is this, right? So like, are you just a phenom, right? Freak phenom, amazing, we know you are. But how realistically, how reproducible is it among other, general surgeons, let's say?
I think it's reproducible. I always tell surgeons, you need to be an advocate for yourself, and you need to be an advocate for your patients. It's just about, we all want to better ourselves, right? We want to master our craft and all that and do well for our patients. Talk to your administration. I've seen surgeons that I've spoken to and just talked through the process go on and be able to do this at their programs. It's absolutely reproducible, but it takes time. It takes our own dedication to really show, the value, and then I think it can be done. And pretty soon, I've been doing acute care almost since I adopted the robot in 2016. More and more surgeons are doing it, maybe not talking about it as much, or hospital programs aren't talking about it as much, but in the next few years, it's just going to be commonplace, like our inguinal hernias.
Right. You'll be fighting for after-hours block time.
Right.
Like, hey, I want to use that this guy's already using it, whatever. Yeah, that'll be interesting.
That's great. Anything else? Any final thoughts you want to add before we let you get out of here between two surgeons?
No, this is great. I think that if for anyone out there that does acute care surgery, even if you haven't adopted the robot yet, I think get trained, and it allows us as maximally invasive surgeons at baseline, because I'm trauma critical care trained, to be able to offer this minimally invasive technology to our patients, and they just do better. So just say, embrace it.
Awesome.
Yeah.
Embrace
Andrea, thanks for joining
Embrace
us.
the grind.
Thank you guys.
RSC, this has been another great episode of Between Two Surgeons. I think this will be a recurrent theme, I think. I like this a lot. So,
As long as Andrea comes.
So obviously post any commentary, and we'll all be on there trying to answer your questions below the feed. So that's it. Andrea, thank you so much.
Thank you guys.
Thanks, boss.
Thanks.
Excellent.
Thank you.